In terms of suicide risk assessment, so let's say you've implemented suicide risk screening, meaning the Columbia or the ASQ in your setting. And it can be implemented, by the way, in primary care, on med-surg floors, for pediatric patients as well as adult populations, as well as in behavioral health care. So let's say they screen positive, then what next? And that what next does depend on the setting. If it is a behavioral health setting, a psychiatric setting, then the suicide risk assessment should be much more sort of full. And what's here on this slide is the more full form of a suicide risk assessment. However, if you work in a primary care setting, there's something called a brief suicide risk assessment that is the step 2 of the ASQ pathway. The ASQ is a 3-tiered pathway that was developed by the NIMH and again, very, very recently validated in both pediatric and adult settings. So again, please don't feel like you blinked and somehow like the world changed. These are very new tools. So in terms of assessing suicide risk, okay, so the person is saying that they're having suicidal thoughts right now or passive thoughts of being perhaps better off dead, they're feeling like a burden, but the current moment of the way that they're thinking is not the full suicide risk assessment, obviously. You need to take a history about previous suicidal thoughts and suicidal behavior, family history of suicides and suicidal behavior, be thinking about other contributing risk factors. What has been happening in the course of the person's depression or PTSD or anxiety? That trajectory matters a lot. Have they been experiencing losses or stressors in their life? And I mean, the problem with that is, at what point in time are any of us not experiencing some kind of stressor or trying times? But nevertheless, periods of transition are high points for vulnerability when other risk factors are present. But look at the protective factors as well. Do they have supports at home and in their environment? Do they have a sense of connection? And you can ask them outright, what are your reasons for living? And there's in fact an inventory called Reasons for Living that can help walk a patient through those sense of connectedness and why they hold on to hope even during periods of suicidal struggle. The level to which a patient is engaged in treatment is an important factor actually in your suicide risk assessment. And then a key part is assess for safety in their environment. And that means you can and should ask about lethal means in the environment. If you feel, if you haven't had training for example, CALM, counseling on lethal means, that's okay. You can start by simply saying, if you don't even have to ask what they have in their environment, you can engage them by saying, if you have any lethal means in your home, such as firearms, toxic substances, chemicals, toxic medications, now would be a good time for us to make sure that there's a plan in place to make your environment safe while you and we together work through and support you through this time. And that's a time also when, if you have had the ability to communicate with family, that's a very important part that the family can play a role in, is making the environment safe. Some of the new developments in the tools that we have in suicide prevention are what we call brief interventions. So these are steps that can be taken even in a primary care setting and certainly should be taken in behavioral health settings as well. Safety planning, again, lethal means counseling as mentioned, timely referrals, and that's usually for primary care to refer them to a mental health provider. But if you're a mental health provider and you're thinking this is a patient who would do better if they could have access to CBT or DBT, then those could be appropriate referrals. And then caring contacts is a remarkable literature. It shows in about 14 different trials that simply sending postcards, emails, text messages, phone calls, and in-person visits between 8 and 12 times over a period of 18 months after a suicidal crisis reduces subsequent suicidal behavior between 40 and 70% when nothing else changes in the treatment plan. So don't underestimate the power of just checking in on someone that you're worried about. And these are some of the more specific suicide risk reducing full psychotherapy treatments. CBT for suicidal patients, but even regular old CBT will do. DBT, attachment-based family therapy. There's something called CAMS, Collaborative Assessment and Management of Suicidality. And medications is its own whole big topic, but what I will say is lithium has a robust literature for reducing suicidal behavior, and it's highly underutilized. And yes, it is tricky because of the narrow therapeutic index and the issues with lithium, but that is something that I would think about if you have a patient who is at higher risk for suicide. And remember that it can also help stabilize their mood disorder, whether it's bipolar or unipolar.